So like green is okay. Hello. Yeah. Okay, I think we'll go ahead and get started. For those watching from remote, for those of you who don't know me, my name is Akshay. I'm one of the critical care fellows, EM background. I did a year ultrasound fellowship as well. So my talk today is going to be on cardiomyopathies and pericardial effusion and tamponade. So these are my objectives for today. I'm not going to go through them. We'll go through them as we're talking. So let's start off with a case. So a 73-year-old gentleman, history of hypertension, CHF, AFib on Eliquis, who presents with worsening shortness of breath and hypotension. He was admitted to the MICU for respiratory failure and worsening lactic acidosis, suspected septic shock. You could see his vitals here. His heart rate's 97, tachypnic. He's hypotensive, blood pressure 80/40, and he's saturating 94% on high flow. In terms of his physical exam, he has dry mucous membranes, cold to touch. He's confused, unable to follow any commands, but moving all extremities. He has an irregular rhythm, and he's tachypnic. So lactic acid has been increasing despite IV fluids. So you decide to do a bedside point of care ultrasound. So for some of these cases, let's do like how we do chest x-ray conference. Let's do like an echo conference and have one of the fellows maybe start off by just saying what imaging window we're looking at and if they want to try to give some findings and their interpretation. Okay, perfect. Yeah, it's a parasternal long axis image. So what are some pertinent findings that you guys think? Okay, so I heard EF is really poor. Good. I heard pericardial effusion in the back. Why do you think there's a pericardial effusion? Do you want to elaborate on that? Okay. Are you talking about this or are you talking about up? Is this what you were talking about? That thing?
No, that's not the.
Yeah, that I agree. That's the aorta. So I agree there's an effusion, but this actually is a pleural effusion. So your aorta, your DTA, and we'll go over this later on, but so there is an effusion, but it's not pericardial. It's actually posterior to your DTA. So this is a large pleural effusion. So as people said, parasternal long axis, left atrium, mitral valve, left ventricle, LVOT, right ventricle up here. And you could see just globally the LV function looks down, and there's a pleural effusion. I don't really see a pericardial effusion. And so we decided to do EPSS. What do you guys think? Kind of confirms what we thought, right? So you're measuring an EPSS of 2.2 centimeters. So just a quick refresher, EPSS, you use M mode across your anterior leaflet of the mitral valve. And so you could see this is your mitral valve down here that you're seeing. This is your E wave, A wave, corresponding to diastole and systole. So E wave is your early ventricular filling, A wave is your atrial kick, and you're measuring the distance between the anterior leaflet of the mitral valve and the septum. And so you could see the further that distance is, suggestive of kind of a depressed ejection fraction. So again, this is limited. EPSS is one of those things that's limited when there's wall motion abnormalities, other things going on. But in this case, a value of 2 is definitely suggestive of diminished ejection fraction. And in studies, generally a value greater than 7 millimeters is considered abnormal. So it's not necessarily great for quantifying, but for an eyeball test, it tells you whether or not the EF is depressed. Okay, a couple more pictures.
With the EPSS, does it matter where exactly you're putting your M mode on? Like, does it have to be at the tip of the anterior leaflet of the mitral valve, or can it be at the base? Is there an accurate way of actually?
Yeah, so ideally you want the question was where you have to put your M mode cursor for EPSS. Ideally, you want it through the center of the leaflet. So ideally, you want to be able to see your E wave and A wave well, kind of like you saw there. So the center of the anterior leaflet of the mitral valve. And so a couple more images. Any fellows, what imaging windows are we looking at here? This one? Perfect. Yeah. So parasternal short axis and a 4-chamber. And just for purposes of time, we'll go through it quickly. So peristernal short axis, you could see globally the LV wall looks hypokinetic, which you guys can all appreciate. Level of the papillary muscles here. In your apical window here, again, you could see the LV looks globally hypokinetic. The RV also looks like it's down as well. And then the left atrium looks dilated as well. And so here's IVC. You can see there's not really any respiratory variation in measuring at about 3 centimeters as well, and looked at his lungs as well. So always when you're doing a volume assessment, it's nice to take a quick look at the lungs. It's just additional information. And so in this case, he's got B lines kind of diffusely. So based on our overall echo, what do you guys think is the diagnosis in this gentleman? Yeah, I think with the hypotension and the worsening heart failure, there was concern for cardiogenic shock. So he ended up getting started on inotropic support. He had a central line place. His SCVO2 was low. His index was calculated at less than 2. They actually ended up starting inotropic support, and his lactate cleared. So that kind of segues into our talk for today. So we're going to be going over cardiomyopathies. So just a little background about the classification of cardiomyopathies. So they are defined as diseases of the myocardium, and they're associated with cardiac dysfunction. So there's different classification systems. Initially, kind of the first classification system that came out was in 1995 from the World Health Organization, and they defined them as heart muscle diseases of unknown cause. And the goal was to try to distinguish these from cardiac dysfunction from a known etiology, whether it be hypertension, ischemic heart disease, valvular heart disease. And so in clinical practice, a lot of times you'll see cardiomyopathy applied to diseases of known cardiovascular causes. I'm sure you've heard like ischemic cardiomyopathy, hypertensive cardiomyopathy, those kind of things. So as a result, they tried to come up with a classification system to consider the etiology and the dominant physiology. And so they subdivided cardiomyopathies into 5 categories: dilated, hypertrophic, restrictive, arrhythmogenic right ventricular cardiomyopathy, and unclassified. And apart from that, they subdefine specific cardiomyopathies used to describe heart muscle diseases with specific cardiac or systemic disorders. And those included ischemic, valvular, and some other causes. More recently, in 2006, the AHA provided a revised classification system. So they defined cardiomyopathies as a heterogeneous group of diseases of the myocardium associated with mechanical and/or electrical dysfunction, which usually exhibit inappropriate ventricular hypertrophy or dilation due to a variety of etiologies that frequently are genetic. And so they ended up classifying them. They classified primary cardiomyopathies when the disease is solely of the heart muscle. And then they subclassified to include a much stronger genetic component. So they had them classified as genetic, acquired, or mixed. And you could see this is kind of what the classification system looked like. And again, it includes some of the original ones we talked about in the World Health Organization classification: HCM, dilated, and then they subclassified. The biggest difference in this was also the inclusion of ion channel disorders. So they included channelopathies, things like long QT syndrome, Brugada, as part of the cardiomyopathy classification as well. And then finally, the European Society proposed a new classification system in 2008, and they defined cardiomyopathy as a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular disease, and congenital heart disease sufficient to cause the observed myocardial abnormality. And so they grouped these specifically into phenotypes and subclassified into, again, familiar and non-familiar forms. And so their hope with this classification was that it might be clinically more relevant to the provider than the AHA classification. But the AHA and the European Society are probably the 2 major classifications that exist today. And so you can see the major cardiomyopathies, like we talked about earlier, are listed here, and then they subclassify them into whether familiar and non-familiar. And so I won't go into this, but you could just see there's tons and tons of different subclassifications within each major subgroup, whether you're talking about dilated, restrictive, or hypertrophic. And so let's go into dilated cardiomyopathy a little bit. So dilated cardiomyopathy is broken up into different groups. Idiopathic dilated cardiomyopathy, or IDC, is a primary myocardial disease of unknown cause. It's characterized by left ventricular or biventricular dilation with impaired myocardial contractility. The average prevalence in US is about 36 cases per 100,000 and accounts for about 10,000 deaths annually. So the cardiac dilation that you see in dysfunction may result from a variety of acquired or hereditary disorders. Now, differentiating idiopathic from secondary causes is important because there's differences in terms of prognosis as well as therapeutic implications based on the underlying etiology of dilated cardiomyopathy. And so some of the known causes that we see of dilated cardiomyopathy, things like ethanol, different metal toxicity, metabolic abnormalities, there's infectious causes. And so this was a study that was done that looked specifically at long-term survival in patients with unexplained cardiomyopathy. They evaluated a little over 1,000 patients with underlying dilated cardiomyopathy, different causes of dilated cardiomyopathy. The majority of patients had IDC or idiopathic, about 50% of them, and they grouped them into categories based on the underlying cause. And so ultimately, compared with patients who had IDC, those with pericardium cardiomyopathy ended up having better survival. So some important prognostic indicators. And then people that had cardiomyopathy due to infiltrative diseases, HIV therapy with doxorubicin and ischemic heart disease ended up having lower survival. And so this is just some of the tables that kind of demonstrate that. You could see the hazard ratio was a little bit lower when you're talking about pericardium cardiomyopathy, and it tended to increase as we mentioned HIV and infiltrative diseases. And this is kind of the same slide. So kind of just highlighting the importance of understanding the underlying etiology that plays an importance in the overall prognosis. So most patients with dilated cardiomyopathy present between the ages of 20 to 50. The most common initial manifestations that you see are signs and symptoms of heart failure, and they generally present with left-sided symptoms, including diminished exercise capacity, dyspnea and exertion, orthopnea, or peripheral edema. So early retrospective studies that looked at patients with dilated cardiomyopathy had initially kind of higher mortality rates. At 1 year, it was close to 30% and 50% at 5 years. Over time, as we've gotten better at treatment and understand more about the underlying disease, better survival rates, and now mortality, 5-year mortality approaches around 20%. So the clinical course is unpredictable, and most deaths are often caused by progressive heart failure. So some key echo findings. You guys correctly talked about our first case, how we felt like this is someone with reduced ejection fraction. So this was a patient that had non-ischemic cardiomyopathy. So he had dilated cardiomyopathy, kind of unclear what the etiology was, but some of the key echo findings you'll see may include left ventricular dilation, normal or reduced septal and free wall thickness, and overall global hypokinesis. Now you can see wall motion abnormalities in dilated cardiomyopathy as well, but generally you think of global hypokinesis. The EF of less than 45% is generally required for the diagnosis, and you may end up seeing some degree of diastolic dysfunction as well. So people tend to have elevated left ventricular filling pressures. In terms of treatment, so the mainstay of treatment is going to be vasodilators. So it's considered standard initial treatment for any patient with symptomatic LV failure. There's been multiple prospective randomized clinical trials that have demonstrated improvement in their functional class, and also has shown a decline in hospitalizations among patients. And so these are just a few of them. I won't go through all of them, but they've had multiple trials. Most of the data that's out there has been done with enalapril and tended to reduce mortality as well as hospitalizations in patients with heart failure. Other treatment, anticoagulation. So the risk of systemic anticoagulation is higher in patients with severe LV dysfunction. It may be considered in patients with reduced EF, and the other primary indication, a lot of these patients with reduced EF tend to have LV apical thrombosis or thrombosis from their low flow state. So those patients also would warrant anticoagulation. Beta blockers are associated with improvement in symptoms, exercise capacity, and LVEF. Metoprolol and carvedilol are the most extensively studied ones. Results from the metoprolol and dilated cardiomyopathy trials showed improved quality of life and better cardiac function in patients treated with metoprolol, but did not actually show a improved survival benefit. AICD, I know this is something that comes up a lot, like especially when we're triaging too. There's this person with a reduced EF. Do they need telemetry? Do they have to come to the ICU because their EF is 15%? So data for prophylactic ICD patients in patients with non-ischemic cardiomyopathy is less strong compared to patients with ischemic. So there's better data out there in ischemic cardiomyopathy where they generally, when they have a reduced EF, they recommend prophylactic ICD treatment. For non-ischemic cardiomyopathy, there's about 3 studies that were done, approximately 660 patients, and they looked at prophylactic ICD in patients with an EF of between 30 to 35%, and all 3 of them showed a non-significant trend towards improved mortality. So current guidelines do recommend prophylactic ICD for patients that have non-ischemic dilated cardiomyopathy whose EF is less than 35, and who are in class 2 or 3 in terms of their heart failure symptoms. Other treatment options, so LVAD, utilized for patients that are failing maximal medical therapy. And here at this institution, I'm sure you guys have seen, we have patients on LVAD either as destination therapy or bridge to transplant. Ultimately, the long term treatment sometimes for cardiomyopathy is cardiac transplantation. So like that, dilated cardiomyopathy remains the principal indication for heart transplantation in both adults and children's, and survival rates are upwards of even 70% at 10 years. The last thing I wanted to talk about when we're talking about treatment is there were some guidelines that were published recently in 2008 that had recommendations for pre-hospital and early in-hospital management of patients with acute heart failure syndromes. So this was a recommendations that were done by a group of cardiologists, intensive care doctors, as well as emergency medicine physicians. And so one of the things I wanted to touch on was specifically NIV. So this is something that we do all the time for patients that come in with decompensated heart failure. And so one of their major recommendations was NIV should be used as early as possible in all acute heart failure syndrome patients when dyspnea, respiratory distress, and/or pulmonary edema are present to prevent the need for intubation and subsequent complications. And so non-invasive respiratory support can be used either as CPAP or BiPAP for these patients. Numerous advantages, including augmenting cardiac output, decreasing RV afterload, increasing your FRC, as well as reducing work of breathing. So the recommendations that they gave were based on 23 clinical trials and 2 large meta-analysis looking at NIV. In the first meta-analysis, both CPAP and BiPAP reduced the need for intubation, and CPAP was associated with a decreased mortality among patients with cardiogenic pulmonary edema. And the second study had similar findings, and BiPAP also tended to have a non-significant improvement in mortality. So something to think about, especially in the ICU, when you have patients where you think cardiogenic pulmonary edema, a good time to think about NIV. So that's dilated cardiomyopathy. Now let's shift gears a little bit and talk about restrictive cardiomyopathy, one of the other major cardiomyopathies that we categorized. So restrictive cardiomyopathy is defined as heart muscle disease that results in impaired ventricular filling with normal or decreased volume of either or both ventricles. So systolic function is usually normal. It can be abnormal in restrictive cardiomyopathy as well. And wall thickness may be normal or increased depending on your underlying cause. So the increased stiffness of your myocardium causes pressure within the ventricles to rise with small increases in volume. It can present with signs of right or left-sided failure. And consider the diagnosis in any patient that comes in with heart failure symptoms, but no clear evidence of cardiomegaly on X-ray or systolic dysfunction. So there's, again, various classifications of the different types of restrictive cardiomyopathy. I won't go into all of those, but you could just see based on the causes. They have myocardial causes as well as endomyocardial causes, different drug effects as well. So the presentation, underlying cause of restrictive cardiomyopathy may not always be obvious on the initial presentation. Symptoms can include dyspnea, P&D, orthopnea, signs and symptoms of heart failure generally. The initial diagnostic approach for restrictive cardiomyopathy should include an attempt to rule out constrictive pericarditis. So for the purposes of time, I won't go too much into constrictive pericarditis today, but constrictive pericarditis and restrictive cardiomyopathy present very, very similarly, and it's quite challenging to differentiate between the two of them in the clinical setting, but it's important to try to figure out what you're dealing with because the prognosis as well as the therapeutic options are different for patients. Diagnosis, you also will think about biomarkers, X-ray, echo, CT/MR, cath, and ultimately maybe a biopsy is how you differentiate between the two. So here's a table that just kind of shows some of the differences between restrictive and constrictive. I won't go into too many details. We're going to talk a little bit later about some of the echo findings, and echo is one of the best ways you can differentiate between the two of them on physical exam. One of the things to think about is murmurs. Regurgitant murmurs are more common in restrictive, less common in constrictive. Sometimes you may see a pericardial knock, especially if they've had recurrent pericarditis and things like that. Also, if they have had a cardiac MR, usually or CT, the pericardium is usually normal in restrictive as opposed to constrictive where you'll see a thickened pericardium. And then, like you said, ultimately they may need a biopsy to help differentiate. So echo findings of restrictive cardiomyopathy features may include like biatrial enlargement, hypertrophied ventricles, initially small LV cavities and normal to depressed systolic function. Additional findings based on like the underlying cause if they have metabolic or infiltrative disease. And as we talked about, echo plays an important role in differentiating between constriction and restrictive type physiology. In this case, parasternal long axis image that we're looking at, you could see the LV wall appears thickened, both the posterior and septal wall overall appear thickened. And this is an example, I think, of a patient who had cardiac amyloidosis. So I won't go into too much of the details because this isn't like an echo talk, but when you're differentiating between restrictive and constrictive cardiomyopathy, this is a nice figure from Mayo that they have an algorithm that you can use to try to help have certain echo findings that are more suggestive of restrictive cardiomyopathy versus constrictive. And one of the most common things that you'll see, and it's, if anyone's sitting for the echo boards, it's like a commonly tested thing, will be looking ultimately at your E prime. So when we do a diastology, one of the things we do is we put tissue Doppler over the medial and lateral mitral annulus. And so that gives you your E prime. So you'll get your E prime, and generally in constrictive pericarditis, you have the E prime ends up being greater than 8 centimeters, as opposed to in restriction, it ends up being less than 6 centimeters. And normally, when patients when they do diastolic function, the lateral E prime is always greater than the medial E prime. So in this case, in constriction, you get the reverse, and so this is actually known as like annulus reversus. So it's one of those findings that you tend to see specifically in constriction and not restriction. There's some other ancillary findings as well, but let me show you an example of what we're talking about. So this is when you do tissue Doppler over your medial and lateral annulus. And so this is the medial, again, this echo, so Mayo does their echoes the other way. So this is actually left ventricle over here, and tissue Doppler over the medial annulus. You can see the medial E prime over here. So E, A wave, E prime is pretty large, greater than 12 centimeters over here, and lateral E prime is less. And so this shows both of them together. So in this case, this figure is someone with constrictive pericarditis. Here's restrictive, and you could see just looking at the figures here. So your medial E prime is greater than your lateral E prime, and it's also much more prominent in constriction as opposed to restriction. So one of those things to keep in mind of for echoes. So when we talk about treatment for restrictive cardiomyopathy, so there's symptomatic therapy depending on their signs and symptoms. So if they are presenting with heart failure type symptoms, everything we talked about with dilated, supporting their breathing, if they need NIV, if they're in decompensated heart failure, diuretics, heart rate control, anticoagulation. Ultimately, you try to focus on disease-specific therapy, and that's why knowing the underlying cause becomes extremely important, depending on whether they have amyloidosis, eosinophilic cardiomyopathy, or some other cause. Try to treat the underlying cause, or if there's a specific toxin. Ultimately, transplantation may be required in these cases as well. It's considered in patients with refractory symptoms, and it's usually not an option in patients with systemic disorders as the cause of restriction. Okay, so we did dilated restrictive. Let's move on to another case here. So 42-year-old female, history of hypertension, who was admitted to the surgical ICU following a lap chole. Post-procedurally, her course is complicated by hypotension despite fluid resuscitation and required Levophed. She arrives to the SICU. You find out that her blood cultures that were taken in the ED are growing gram-negative bacteria. She's afebrile, she's tachycardic, tachypnic. Blood pressure is 100/55 on 8 mics of levo. She's on the vent currently. She appears in moderate distress. There's a murmur that's present. She's tachypnic and diminished at the basis. So lactic acid is increasing and your vasopressor requirements have slowly been going up in the last hour despite IV fluids. So you decide to do a bedside ultrasound. And so we'll continue with participation for this part. Any fellows want to take a shot at what imaging window we're looking at and an overall interpretation? Okay, everyone agrees it's a peristernal long axis image. Perfect. So that's step one. So we know what we're looking at. And so looking at our normal anatomy from what we saw before, what do you guys think we're looking at? Which wall? Okay, I agree. What do you, so like left atrium, mitral valve, LV, LVOT over here, aortic valve, right ventricle. And so a lot of people in the audience are saying the walls look, oh, so I can replay it, look very thick. So they're specifically commenting on the septal wall being thick. The posterior wall as well, maybe, but definitely the septal wall looks abnormal. I agree. And so you put M mode over it as well. And what you end up seeing here is, so here's similar to what we did before. When we did EPSS, you're doing M mode. So you're getting a two-dimensional representation over this point. And again, you have your mitral valve over here. And you could see, you start to see your E and A waves kind of coming in here. But over here, you start to see the mitral valve kind of going forward in systole. So you're starting to see some evidence of SAM, also known as like systolic anterior motion of your mitral valve. And over here, you could see this is all septum, so evidence of like septal hypertrophy. Great. So based on this, what's going on? What do you guys think the diagnosis is? Yeah, so everyone here is saying some type of LVOT obstruction is probably contributing to her hemodynamics. So we'll talk a little bit more later on at the end of this part about the management of that. So that segues us into hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is a genetically determined heart muscle disease due to mutations in one of several sarcomere genes. It's characterized by left ventricular hypertrophy of various morphologies and a broad spectrum of clinical manifestations. So many patients may end up having no symptoms at all or minor symptoms. A lot of times these patients end up getting diagnosed as part of like a routine family screening. So they had an early death in the family from an unknown cause, sudden cardiac death. There's a routine detection of a murmur by a PCP or an abnormal EKG. Signs and symptoms are variable and it doesn't necessarily correlate with the degree of LVOT obstruction. So signs can include, dyspnea exertion, fatigue, atypical chest pain, pre-syncope or syncope, palpitations. One of the most feared complications of someone with acute LVOT obstruction is if they start to develop acute hemodynamic collapse, likely in the case of the patient we just presented. So it can be seen in patients with HCM with LVOT obstruction, and it's manifested by signs and symptoms of heart failure and severe hypotension. So it can be precipitated by any event that increases the degree of obstruction across your LVOT. And so that can be seen in the setting of decreased preload, whether it's someone that's hypovolemic or anemic, whether it's someone that has, sepsis and is in a hyperdynamic type state. You can see it in the case of decreased afterload, so someone on vasodilators. Also can see it if then there's some type of atrial arrhythmia or tachyarrhythmia in acute MR. So the diagnosis of hypertrophic cardiomyopathy, it's generally a comprehensive history and physical, EKG, cardiac imaging to identify LVH, and generally some way of quantifying the degree of LVH as well. So usually echo is pretty good and can reliably establish the degree of LVH, but sometimes you may require cardiac MR. And for a lot of these patients that are diagnosed with LVH and some type of LVOT obstruction, they undergo ambulatory EKG monitor and exercise stress testing to get an idea about prognosis and to risk stratify these patients. So some of the echo findings, so characteristic features include variable degrees of RV and LV hypertrophy, specifically in HOCM. You can see systolic anterior motion of the mitral valve like we saw in our patient in the presence of LVOT obstruction. Your LV wall thickness may be greater than 13 millimeters without an apparent cause, or the ratio of your septal to posterior wall is greater than 1.3. So in that patient, we didn't measure it, but it was closer to almost 2. And the degree of LVOT obstruction is also important because it has important prognostic value in patients. And so this was a large study that was done that looked specifically at the effect of LVOT obstruction on the clinical outcome of patients with hypertrophic cardiomyopathy. And so they, in this study, assessed the effect of outflow tract obstruction on morbidity and mortality in patients. They had about 1,000 patients, and 273 of these patients had some type of obstruction of their LVOT. So all 1,000 patients had HOCM. And specifically, patients were defined as having an obstruction if they had a peak instantaneous gradient across the LVOT of at least 30 millimeters of mercury. So this study was important because overall, the probability of death related to HCM was significantly greater among patients with outflow obstruction, and the likelihood of severe symptoms and death did not necessarily increase as the gradient increased above 30. So 30 has become kind of an important cutoff that they use for prognostication, but also for therapeutic interventions. So you can see just a couple of figures here. So you could see this is the likelihood of deaths from HCM and then likelihood of deaths from any cause. And it was increasing, the probability of sudden cardiac death was increasing among patients that had some degree of obstruction. And this figure specifically looked at independent risk factors associated with death. And again, the cutoff of 30 was independently associated with a higher risk of death from any cause or from hypertrophic cardiomyopathy. Other things that were independently associated with a higher risk of death was patients that had a higher NYHA class when they were entered into the study, patients that had underlying AFib, if they had an LV thickness that was greater than 3 millimeters, and also females, but there was not statistical significance there. And this was just interesting because it showed that despite the gradient increasing, even if the gradient was between 50 to 69 or greater than 70, there was not necessarily a difference in mortality among this group with different gradients. That's why 30 has become kind of an important number. In terms of management of these patients, so for asymptomatic patients, we don't routinely receive any treatment because there's really no evidence that pharmacotherapy alters your disease progression at all. For symptomatic patients with LVOT obstruction, the mainstay of therapy is some type of negative inotropic agent. Generally, beta blockers are considered first line, or non-dihydropyridine calcium channel blockers such as verapamil can be used in certain cases as well. This is kind of a good algorithm here for how to decide on treatment, which sometimes they use in the outpatient setting. So generally, beta blockers are considered your monotherapy will be your first line of symptoms. If symptoms persist despite that, you can consider adding on a second agent or a non-dihydropyridine calcium channel blocker. If symptoms still persist despite that, then options include possible surgical septal myomectomy or alcohol septal ablation. In terms of surgery, surgical septal reduction is recommended for individuals that have symptoms refractory to medical treatment and a gradient, resting gradient greater than 50, and indications for percutaneous alcoholic septal ablation, reduction include a septal thickness greater than 1.8 millimeter, greater than 18 millimeters of mercury, or a resting gradient greater than 30. So going back to our initial case, so we were concerned that this is someone that has obstructive cardiomyopathy with LVOT obstruction in hemodynamic collapse. So when we talk about management of these patients, a couple of important things we can do to support their cardiac output, optimizing their preload. So for these patients, IV fluids, correction of any underlying anemia. One of the few instances where phenylephrine is actually going to be your vasopressor of choice. It's something we don't think use as often in the ICU for different reasons, but in this specific case, even someone with septic shock, if they're showing you evidence of hemodynamic collapse, I would use phenylephrine if they have significant LVOT obstruction. Avoidance of inotropes and vasodilators, and finally, consideration of beta blockers if you need to try to control their heart rate as well. So the last cardiomyopathy we'll talk about is going to be Takotsubo. So Takotsubo, or stress cardiomyopathy, was first described in Japan in 1990. As I'm sure you guys all know, it derives its name from an octopus pot in Japan. It's kind of cool, and that's what the LV angiogram looks like. So the clinical presentation is similar to that of ACS. A lot of times patients present with STEMI, NSTEMI, or unstable angina. The onset is generally due to some type of emotional or physical stress, and the most common presenting symptoms include chest pain, dyspnea, and or syncope. So for the diagnosis, EKG abnormalities are common. ST elevations are the most common abnormalities that you'll see almost in 44% of patients. You can see ST depressions. Cardiac biomarkers show your troponins tend to be elevated, but they don't tend to be elevated as high as like a true coronary event. And because of this, patients generally require cardiac catheterization regardless, because they're presenting as a STEMI. And when they do cath these patients, they tend to have normal coronary arteries with apical ballooning on your LV angiogram. This is a proposed criteria by Mayo for the diagnosis of Takotsubo, or transient left ventricular apical ballooning. And so all four of these symptoms are generally present to diagnose it, which we kind of talked about. So some of the echo findings, the most common type that you'll see is the apical type. So you get systolic apical ballooning of the LV with hypokinesis of your mid and apical walls and hyperkinesis of the basal wall. So you could see this is apical four-chamber view. So left atrium, left ventricle over here. You can see up here the LV apex almost looks kind of like a balloon. And then you could see the basal walls are definitely pretty hyperdynamic compared to out here when you're looking at your mid and apical walls. So mid to apical hypokinesis with hyperkinesis over here. And this pattern is present in over 80% of cases with Takotsubo. You have atypical variants, so like a mid-ventricular type, a basal type, which you'll sometimes hear referred to as reverse Takotsubo, where the base is actually hypokinetic and your apex is hyperdynamic. You can also have a focal type or global type. So why we care about this is there are multiple complications associated with Takotsubo, from just decompensated heart failure to frank cardiogenic shock and death. And so this was a large study that looked at the clinical outcomes of patients with stress-induced cardiomyopathy, and they looked at patients from the International Takotsubo Registry that included 26 centers in Europe and the US. And out of the 1,700 patients that they had with Takotsubo, 90% of them were women, much more common in women. Sorry, I don't know why. The rates of neurologic or psychiatric disorders were higher compared to patients with true ACS. So you could see almost 55% had some type of underlying neurologic disorder, and almost 25% had some type of psychiatric disorder. I won't go too into detail on this table, but the important thing was when you look at in-hospital outcomes for patients that had Takotsubo cardiomyopathy versus ACS, pretty significant in terms of the amount of individuals that were progressing to cardiogenic shock versus mortality. Almost 10% of patients progressed to cardiogenic shock, which was similar to patients with ACS, and almost 4% died, which was also similar to ACS. Independent predictors of in-hospital complications in the study included physical triggers, patients that had high troponin levels on initial presentation, and also low EF on admission. So in terms of management is generally focused on supportive care. It's generally a transient disorder, and with resolution of the stressor, it tends to resolve. 10%, like we talked about, are at risk of progression to cardiogenic shock. Most patients recover their systolic function within 1 to 4 weeks. And during long-term follow-up, the risk of major adverse cardiac and cerebrovascular events was about 9.9 per patient per year. Okay, so our last case of the day. So we have a 78-year-old gentleman with hypertension, COPD, ESRD admitted to the MICU for respiratory failure and missed dialysis. He's on BiPAP, and you're called to the bedside due to worsening mental status and hypotension. So he's tachypnic, hypotensive, 80/40. He's on BiPAP, 12/5, FiO2 of 50%. He's confused on exam, not able to follow commands, groaning, has a regular rhythm, and he's tachypnic. So you give him a liter of fluid, he's still hypotensive, thinking about starting pressors, and you decide to do a bedside echo in the interim. All right, so our last case, anybody wanna, this should be an easy one. Anybody wanna take a shot? Great, what imaging window? Great. So peristernal lung, I'm hearing a large pericardial effusion. Compared to the other case, right, when we were talking about pericardial versus pleural effusion, this is clearly a pericardial effusion, right? You see your DTA down here, and all this is pericardial fluid. The other thing you can do, so this is, again, an apical 4-chamber view, and again, you're seeing circumferential pericardial effusion. This one isn't as pronounced as the other image. IVC, non-collapsible, dilated. And so, yeah, so pericardial tamponade is what you're concerned about. So that'll be the last part of this talk. So pericardial effusions, it's any collection of fluid or blood within the pericardial sac. There's different causes, traumatic versus non-traumatic. We probably don't see a whole lot of traumatic causes in the medical ICU, but it is something you need to have high clinical suspicion for after blunt or penetrating trauma, especially when you're also in the SICU. Sometimes they'll have late presenting evidence of effusions. Non-traumatics is a little more difficult to identify because patients have non-specific symptoms, and a lot of times they've had a pericardial effusion for a while, and they may progress ultimately to tamponade. So just a little bit quickly, a review of the anatomy of the pericardium. So there's the fibrous pericardium, which is the outermost layer, the serous pericardium, which includes your parietal and visceral layers. And between the two, you have the pericardial space, which normally has anywhere from 5 to 10 cc's of fluid. There's different causes of pericardial effusion. Some of the things to think about in our patients, obviously the case above, ESRD, patients are at risk for pericardial effusion. Obviously anybody with any type of cardiac surgery, a lot of times they're at risk for more localized pericardial effusions, trauma. So how do we diagnose pericardial effusions by echo? So generally it's a hypoechoic collection that's visualized surrounding the heart. Sometimes it can be confused anteriorly with a fat pad. And the evaluation consists of multiple echo windows. A lot of times you may see what looks like an effusion on a peristernal long axis view, and then all of a sudden, you know, you're looking subxiphoid or apically and you're not seeing it. So maybe what you were seeing was just a fat pad and you're not seeing it in other windows. It's classified as small, moderate, or large. So small being less than 1 centimeter. And that's the maximal dimension that you measure at the largest area that you're seeing the effusion. So large, greater than 2 centimeters. So how well can emergency physicians detect pericardial effusions? So I know everyone here are critical care physicians, but you know, you guys are pretty savvy with ultrasound too. So they did pretty well. Almost the overall accuracy they were saying was about 98%. So this is something that's pretty easy to do. You can rapidly diagnose at the bedside. Is something that we should be able to do if there's clinical suspicion for it. So this is something that came up earlier when we were talking about pleural versus pericardial fluid. And you guys talked about the aorta. So that's why in your plaques views, a lot of times you can start with increased depth when you're looking at your plaques view just to see if there's a pleural effusion to start with. And generally your DTA is going to be your landmark. So pericardial effusions are going to sit anterior to your DTA. Pleural effusions will be posterior to your DTA in this case. So here's an example of both. I guess that clip's not playing, but here we go. No, that's not it. That's just pericardial fluid. But the image has it. So you can see a large pleural effusion here, and then the pericardial effusion that's anterior. And so why we care about this is you worry about the progression to tamponade, right? That's our most feared complication, and we want to be able to diagnose that. Beck's triad, just as a refresher, hypotension, JVD, muffled heart sounds. A lot of times you're not going to see all of those, and a lot of times you'll start to see echo findings of tamponade before you even have clinical signs suggestive of tamponade. So traditionally, it's diagnosed via symptoms and physical exam. On echo, you look for the presence of a pericardial effusion and echo findings suggestive of tamponade, which we'll go over. And normal intrapericardial pressures range from anywhere from -5 to +5 centimeters and fluctuates with respiration. And always keep in mind, tamponade is a clinical diagnosis. So even though you see echo findings suggestive of tamponade, they may not be showing clinical signs of tamponade yet, but you do want to be able to diagnose it earlier so you're able to intervene before they're in frank shock. So tamponade is determined based on how quickly the fluid accumulates. Acutely, it can occur with as little as 150 cc's. It tends to depend on whether it's an acute or chronic pericardial effusion. Generally, there's a steep rise in pericardial pressures that makes tamponade kind of a last drop phenomena. So there's a critical threshold where the limit of your pericardial stretch is reached, and just a few cc's can put you in frank shock, and if untreated can lead to hypotension, PA, death. And so here's just an example of showing that when you have a slow pericardial effusion, the limit of your pericardial stretch tends to be much longer, so you reach that threshold for tamponade much later, as opposed to, this is why a lot of times in traumatic cases, patients very quickly from even a few cc's of blood can go into quick frank tamponade. So this is just a quick review of some of the normal cyclical variation of your left and right heart with the respiratory cycle. The only reason I bring this up is it's going to help when we go through some of the echo findings. So normally during inspiration, you get a decrease in intrathoracic and intrapericardial pressures. You get augmented flow into the right heart, and ultimately a decrease in LV stroke volume with early inspiration. And the opposite is seen in expiration. So these are the echo signs of tamponade. So let's go through them quickly. So the first sign is going to be right atrial collapse and atrial systole. So it's actually the earliest echo sign that you may see of tamponade. And the reason why is the pressure in the right atrium is lower than in the right ventricle. So you'll start to see findings in the right atrium even before you see it in the right ventricle. There's variable sensitivities and specificities, and it's best going to be seen in your apical four-chamber view or your subxiphoid view. So here's a good example, a apical four-chamber view. And if you focus on the right atrium here, you could see kind of the swinging of the right atrium, specifically in systole, it's collapsing. So you may see that. And if you actually look at the RV, you're not seeing any RV collapse just yet either. So the second finding, RV collapse during diastole. This actually has the highest specificity for tamponade. It has low sensitivity. Another tip you can use is utilizing M mode over your RVOT, and I'll show you an example of that. And this is best seen in your plaques, your parasternal short at the base, apical four or subxiphoid. And so here's an example of, from our previous image, you could see the right ventricle up here collapsing in diastole. And so here's an example of M mode over your RVOT. And again, we talked about this tracing before. So if this is diastole corresponding to your E and A wave, you're seeing the right ventricle during diastole. Over here, if this is your RV wall, you're seeing it getting pushed into during diastole. Plethoric IVC, this is kind of one of the big signs. A lot of times what I've been taught is if you think it's tamponade and your IVC is collapsible, it's probably not. And so that's one of the quick views I'll go to right away. And so a dilated IVC has a very high sensitivity for tamponade. And the last thing that we'll talk about is just mitral valve and tricuspid valve inflow velocity variation. So you use Doppler to look at the velocity, the inflow velocities across the mitral and tricuspid valve. And this is kind of the echo diagnosis of pulsus paradoxus, if you will. So we talked about the respiratory variations in your hemodynamics, and you can kind of see this. It tends to be exaggerated in tamponade. So normally your peak mitral inflow velocity varies by 15% or less with inspiration, and tricuspid is 25% or less. And with a significant effusion, you tend to have an increase in ventricular interdependence, and you'll see an exaggerated response. And so what this means is, and so the actual numbers is in tamponade, you'll have a 25% decrease in mitral valve inflow velocity and a 40% increase in tricuspid valve inflow velocity with inspiration. And so you generally do this in your apical 4-chamber view. And so this is just a schematic of what it looks like, but let me show you on the echo image. So you generally have your pulse wave Doppler right past your mitral valve, and this is how you get your mitral valve inflow velocities. And this is what your inflow velocities are going to look like as you get your E and A waves here. And specifically, during inspiration to expiration, you're looking at the change in velocity. So you could see in this case, expiration to inspiration, the change is much more than 25%. And so here's an example of both. This is tricuspid velocities, mitral, and again, you're looking at the change. You could see this is a pretty significant change between inspiration and expiration. So those are your echo findings of essentially pulsus paradoxus. And so this is kind of the last thing we'll touch on is pericardiocentesis. So ultimately, the patient we had in our case would need an emergent pericardiocentesis. Generally, blind approach tends to have more serious complications. Ideally, you want to do these under fluoro. So most of the times our CICU or whoever interventional cardiology will take them to the cath lab and do this under fluoro. If you have to do it at the bedside, utilizing ultrasound has been shown to improve your chances of success in reducing complications. And so this is just a quick, so ideally what you do is your ideal site of needle entry is going to be your largest fluid accumulation. So where you see the largest amount of fluid is where you want to go. So if that is, apically, then that's where you're going to go. Subxiphoid, if that's where you see it, that's where you're going to end up going. And the direction of ultrasound beam is going to be one that avoids any target structures. You also can use agitated saline. And so here's an example, which using agitated saline just to kind of light up the pericardial space, and that might make it easier when you're trying to potentially pass a wire. That's all I got. So thank you for your attention. Any questions?
That was an excellent talk. Thank you. This is Riyad from the Neuro ICU. I just had a question regarding your sort of recommendations of anticoagulation, VK versus DOACs and non-valvular, non-AFib associated cardiomyopathies.
Sorry, can you say that a little bit louder? We couldn't really hear.
Okay, can you hear me now? A little bit better?
Yeah, that's better.
Okay, awesome. I was just sort of trying to get your opinion or recommendations as far as anticoagulation, type of anticoagulation in non-valvular cardiomyopathies that are not associated with, arrhythmias like AFib or A-flutter.
Oh, yeah. I think, so we were talking about utilizing anticoagulation for people that have, if they have some type of LV thrombus or if they have a reduced ejection fraction in a low flow state. I actually didn't see anything that specifically commented on DOACs versus Coumadin. From what they were mentioning, any type of systemic anticoagulation would be appropriate in those patients based on kind of what the underlying condition was.
This is Jillian. Can you hear me?
Yeah.
So actually for LV thrombus, there has been increased complications for DOAC. So really the guidelines still stick with the Coumadin for 3 months. The one thing I will say kind of as a side point is the guidelines still say anticoagulate for 3 months for LV thrombus, which to me and a lot of the heart failure community doesn't really make a lot of sense, because unless you have clearly changed the reason why you have the thrombus, then who's to say that that won't come back unless it was an acute MI that you have recovery of myocardial function. So a lot of times what we'll do is treat with Coumadin upfront for that 3 months per the guidelines, and then switch over to DOACs after then for more kind of long-term anticoagulation past that time.
Thank you. That makes sense. That's very helpful.
Thank you.
Any other questions?